Okay, we're going to start off with Dr. Douek. Danny is at the National Vaccine Center at NIH, and he's been involved with a lot of work on HIV pathogenesis going back in the day, how the immune system responds, and then transitioned over to thinking about how do you get rid of the reservoir cells that are the barrier between us getting patients cured, rid of the HIV, sort of like we do with hepatitis C. You treat hepatitis C for 8 weeks and they're cured, the virus is gone. HIV, not so easy, and he's going to give us an update on that. More recently, he's been working on COVID and got really involved in the pandemic. But today we're going to focus on cure. Danny, welcome.
Thank you for the clap.
Yeah, that's later talk.
Yeah, right. Morning, everyone. Thank you for being here. It's a real pleasure to be here. Thank you, Mike. So where are we, and do we have a map? Let me just go. Yeah, I have no financial relationships with anyone except my mortgage. That's all I can think of, sadly. These are the learning objectives. I'm not going to go through this because that's what the talk is about. So I've given a lot of cure talks over many years. I often recycle them. I started this one from scratch because I thought it was time for a little bit more honesty about the subject. And I've been talking to my colleagues like Steve Deeks about this over the last few months. It's not that I wasn't honest before, but I'm not going to spend a lot of time dwelling over a vaccine approach to the cure that is safe, which is a euphemism for doesn't work. I'm not going to talk about encouraging mouse models of HIV cure. I'm not going to show you lots of experiments in monkeys that look very encouraging, fascinating. I hope I'm not going to depress you, because I am by nature a stupidly optimistic person. So we'll see where we go. But in my discussions with Steve Deeks, we've asked ourselves, well, why do we need a cure? I mean, we used to do pathogenesis. Do we actually need a cure? Because we have effective and continuously improving ART, especially with the long-acting formulations that you're going to be hearing about. So we have 1.5 million new infections in 2021. That's 1 million more than the global targets. The incidence is increasing in Eastern Europe, Central Asia, the Middle East and North Africa, Latin America. The number of people on ART grew more slowly in 21 than it had in over a decade. AIDS took a life every minute in 2021. And global funding has decreased 57% in the past decade. So all is not good. Let's think about the costs, and you know all of these. So the human costs, such as the stigma, discrimination, and criminalization of simply being HIV infected. ART needs to be administered indefinitely. It can be toxic. There is multi-drug resistance, and of course, there are the long-term health consequences, such as obesity, comorbidities, inflammation, polypharmacy, and there still remains a mortality gap in HIV-infected people, even when they are fully suppressed on ART. Apart from the human, the personal costs, there are, of course, public health and economic costs. ART is a financial burden on healthcare systems. $50 billion was spent on HIV/AIDS just in the past year. Social disruptions such as the mere suffering and job losses, and of course, access. Of the 40 million people with HIV in the world, a quarter, 10 million, are not on ART. And that includes 50% of all children who have HIV infection. But then if we decide, well, maybe we do need a cure, we have to ask ourselves, well, what does a cure look like? Because as you guys know, there is a whole spectrum of how people with HIV fare on ART. Some are well, with no problems of adherence or access or anything else, and some are not doing so well for many various reasons. You know what they are because you're looking after them. So within that spectrum, what we need to do is offer a range of effective, scalable, and safe options. These are the three pillars: effective, scalable, safe, all at the same time. Some individuals are happy to remain on their current regimens. Some want their virus completely eliminated. We can call that a true cure. Others do not want or cannot take ART for various reasons, and so for there we have to look towards remission strategies, and we're going to discuss those in the talk. But this is the problem. Currently, we have nothing that even remotely looks effective, scalable, and safe. And this is being honest. This is the situation that we're in at the moment, and we're going to discuss this. That's the problem on a high scale. The problem on a molecular scale is the HIV reservoir. And what we're talking about when we're talking about the HIV reservoir is the reservoir that matters. And this is the definition: replication competent, intact HIV proviruses that live in quiescent CD4 T cells that persist during ART and can potentially wake up and make infectious virions at any time. Okay? That's the reservoir. Now, in my usual talks, I would spend the next 10 slides going through what's the reservoir, what cells is it in, how do we define those cells, where are they in the body, so on and so forth. I'm not going to do that now because I can summarize it in a few lines. We've spent decades defining these cells phenotypically and transcriptionally. What do we do? What do we know? As we'd expect, 99% of them are in lymphoid tissues: spleen, lymph nodes, gut, so on. And that reservoir is a tiny population, and it's the source of the recrudescent virus on ART interruption. Which cells are infected, so on and so forth, very, very diverse phenotypes, and that reservoir is maintained by multiple cellular mechanisms. The problem is that we have no validated biomarker that identifies the rebound competent reservoir. It's diverse. So a true cure in those terms involves the complete eradication or disruption of all replication competent proviruses within an individual. A true cure is difficult to achieve and difficult to prove. So what's remission then? Remission is durable control of this reservoir without persistent therapeutic intervention. But it's problematic because the question that the infected individual will be asking and what their doctor will be asking is, will it come back? It's the same as a person who has cancer, who's in remission. You're always asking, will it come back? And will it thus pose a major risk to that individual and to their sexual partners? So we have these beautiful, rare examples of total cure. We all remember Timothy Brown, who is sadly missed, and more recently Paul Edmonds, some in between. And the majority of those were cured through a transplantation, blood transplant, with blood from a delta CCR5 homozygous donor, so uninfectable cells. And these are proofs of concept that a true cure is possible, but these will not likely translate into scalable approaches, and they're far from safe. There are many more examples of remission, and we're going to go over these in the rest of the talk, but for example, the Visconti, Spartak, and Champ post-ART control cohorts. And what happened in these examples is that more than 10% of these individuals were able to control virus to below 1,000 copies per mil after ART interruption. And so what these do is provide viable pathways for scalable approaches, but the question is, are they effective? They may be safe, they may be scalable, are they effective? And the problem is this: the problem is that the virus keeps coming back. So here's an example that Debbie Persaud gave at Croy in this year. What I'm showing you here are 6 children confirmed infected in utero who received ART within 24 to 48 hours of birth, and they had an analytic therapy interruption, that's what ATI stands for, at 5 years of age, and virus came back in 3 of them, and I'm going to show you on this board over here, at 3 weeks, 8 weeks, and 80 weeks after ATI. This example from Tim Henrich's paper from 2017, an individual who initiated ART on the day of exposure, within hours of exposure, had no detectable reservoir. The estimated size of the reservoir was about 100 replication-competent virions, and yet, 8 months after the ATI, virus recrudesced, and the origin was from a single virus, and we know that because it was sequenced. So, unfortunately, we have no biomarker that predicts post-treatment control or time to rebound. There's nothing that we can use to predict that. And there's no validated immunologic correlate at the moment of post-ART control. So we're a little bit in the dark. So where are we in terms of clinical strategies for an HIV cure? On one side, we can target the infected cell with very early ART, latency reversal, latency silencing, and gene editing. We can also enhance immunity with BNAbs, broadly neutralizing monoclonal antibodies, T-cell vaccines, various forms of immunomodulation, and CAR T-cells, chimeric antigen receptor T-cells. And I'm going to be talking about all of these except CAR T-cells. What's important to understand is that most approaches involve combinations of reservoir reduction and immune enhancement, and there is a rapidly growing interest in gene therapy. So let's begin with very early ART. It doesn't work. Certainly, early ART, if you start ART here within 2 weeks of infection, it reduces the size of the reservoir compared to if you start treating later. However, whether you treat in chronic infection, Febig 3-4, or very early with Febig 1, there is no clinically significant delay in time to virus rebound. So we're up against the limit here. And if we think about treating even earlier, then we're talking about pre-exposure prophylaxis. So let's put that approach to bed. Latency reversal. This is also known as shock and kill. And the principle here is that you have your infected cell here, your quiescent latent reservoir here, and you come in with what are called latency reversing agents, LRAs. And they wake up the HIV genome in some way. That makes HIV RNA, HIV proteins. You do this under the cover of ART, and then you're supposed to get immune-mediated clearance and virus-mediated toxicity, so that reservoir cell then dies and gets removed from the system. There are many approaches that involve things like epigenetic modifiers, TLR agonists, T-cell receptor activators, and so on. Where are we? In vivo, many LRAs slightly increase HIV transcription. That's that stage here. But there is no decline in the HIV-specific reservoir. Activation using LRAs of CD4 T cells is inefficient, tissue-specific, cell type-specific, and virus state-specific. Basically, it doesn't work very well. And more potent, less toxic LRAs, such as SMAC mimetics, that have been tried recently show no change in reservoir size or rebound delay. And also, there is no kill. Infected cells seem to be relatively resistant to killing, and the virus, of course, has escaped immunity by this stage of the infection. So LRAs don't work. Latency silencing is something I find fascinating and I'm hopeful. It's very early days, but I'm going to just mention one example here. So latency silencing is also called block and lock. The idea is to lock the integrated HIV genome into a very deep transcriptional state of silencing, so it can't be woken up. Now, the drug spironolactone, many of you are familiar with it, also triggers the degradation of this transcription factor. And spironolactone suppresses HIV infection in vitro by inhibiting its transcription. It inhibits HIV reactivation from latency in resting CD4 T cells in aviremic people with HIV. The problem is that HIV transcription resumes immediately upon removal of spironolactone. Either way, it's an interesting and diametrically opposed approach to shock and kill. And the reason I'm putting this up here is that clinical trials are planned in Brazil very soon in HIV-negative people to confirm whether the biology of this approach makes sense. Okay, let's move on. Immunologic approaches to an HIV cure. So what rationale do we have for using immunologic approaches? Well, there are the seminal studies of post-ART virus control, such as the Visconti study and the CHAMP study. Generally speaking, about 10% of people who start ART early, but not too early, and remain on therapy for years, exhibit at least partial control after ART is interrupted. So what we want to do is better than 10%. We know that a low reservoir size is required for this post-ART control, but it's not sufficient. As for the mechanisms of how this work, those mechanisms of control that are emerging from most interventional studies to date suggest that what you need are functional CD8 T cell cytotoxic responses, and for those CD8 T cells to have proliferative capacity. They need to work, they need to be able to divide. And there's potentially a role for innate immunity, such as NK cells. So what's the goal of the immunologic intervention? Well, here you can see virus load coming up on infection. ART suppresses it for months to years. And then you would have immune intervention around this time between being on therapy and being off therapy. And the immune intervention would activate a coordinated response involving the innate and adaptive arms of the immune system. You can see all the various players there. Such that when you stop therapy, these interventions would accelerate and augment this effective immunity to intercept virus recrudescence at this time point here and lead to long-term control of ART. One approach is therapeutic vaccines. So I'm at the Vaccine Research Center at the NIH. This is what I do. I know vaccines. This doesn't work. More than 2 decades of approaches have largely failed. Here's a list of some of the studies in the past there. Here are a few studies, very recent studies, using encoded conserved HIV regions as the immunogen. The delivery mechanism is a chimp adenovirus, a bit like the AstraZeneca COVID vaccine, and a boost with a modified vaccinia virus. The ALIX 02 and 03 studies had no impact on time to rebound, rise in virus load, peak virus load, or set point. The RIVER study had no impact on time to rebound, rise in virus load, peak virus load, set point, or reservoir size. The solutions, what types of vaccines, are multiple. RNA, DNA, peptides, virus vectors, dendritic cells, what have you. Why they don't work, there are many problems. Weak immunogenicity, pre-existing immunodominant responses, virus epitope escape, high virus burden, inflammation and its associated immunosuppression, and of course, immune-privileged tissue sanctuaries. So there are many barriers to therapeutic vaccine efficacy, and I think that approach should probably be put to bed as well. So how about immune modulation? Well, we can look at activation of the immune system. Now, you'll be familiar with immune checkpoint molecules such as PD-1 and CTLA-4 on T cells and antigen-presenting cells. And these molecules are part of a large regulatory network that generally suppresses immune responses. An immune checkpoint blockade with antibodies such as anti-PD-1 non-specifically enhances immunity and has been tremendously successful in the treatment of many cancers. It's really a game changer, and there are many more approaches and more successes. Now, we know that immune checkpoint blockade in vitro and in animal models reverses HIV latency and enhances CD8 T cell killing of infected cells. What about studies in people? Is there a hint that there's something working? So this is a study that was shown at CROI. This is a clinical study of an anti-PD-1 monoclonal called budigalimab. There were 2 stages to this study. Stage 1 was budigalimab was given pre-acute analytic therapy interruption, and it did not affect viral load dynamics. You can see the stage 1 is the gray lines here. Virus just comes straight back. Stage 2, the monoclonal was given every 2 weeks during the initial phases of the ATI, and you can see that that induced partial control in 6 out of the 9 participants. So that's pretty good, and I'm very hopeful about this approach. Another approach with immune modulation is suppression, and this is an approach that's local. This comes out of Emory. So this drug, ruxolitinib, is an immune-modulating drug that affects cellular proliferation, immune regulation, and inflammation, and it's used successfully to treat graft-versus-host disease. So this was a phase 2A trial of 60 adults with HIV with stable virus suppression on ART and a good CD4 count. So ruxolitinib was added to this regimen for 5 weeks, and it showed decreased markers of immune activation and cell survival. And in terms of the virus reservoir, what they found was a decline in proviral DNA from week 5 to week 12 in participants who had a high viral reservoir. Overall, there was no difference. But those individuals with a high virus reservoir, there was a significant decay. And what they estimated, and this is merely a calculation, is that based on the virus decay rate, 99.99% of virus clearance could be achieved in 3 years. So I'm quite hopeful about this approach as well. Now let's come to something that I adore. I love monoclonal antibodies. I spend a lot of my life making monoclonal antibodies. There's multiple modes of action of monoclonals. Monoclonals can neutralize free virus to prevent them from infecting CD4 T cells. They can bind to free virus, which is then phagocytosed by a cell like a macrophage. They can also bind to infected cells, which allows NK cells or complement to kill those infected cells. Now, this is the HIV envelope. Here it is. And there are lots of sites on the envelope that are targets for monoclonal antibodies, such as the CD4 binding site here. And they block binding, they bind to this envelope. This is the virus membrane down here. And over the years, we have discovered and developed an enormous amount of monoclonal antibodies here. Many broadly neutralizing antibodies with a range of specificities, breadth, and potency have been discovered and developed. And when I was discussing this slide with Steve Deeks a few weeks ago, he showed me the slide that he uses, and it has a different title from mine. And it says, a broad range and something like an rapidly increasing number of monoclonal antibodies being discovered and developed. And I said to him, you know, Steve, that's not true, because we're in a kind of dire situation at the moment. So a whole bunch of them are no longer in clinical development because of problems such as short half-life, poor manufacturability, low potency, poor PK, and safety. So we can take out half the monoclonals already because we just can't make some of them. And then a lot of them have had their availability drastically reduced because they've been licensed to for-profit companies, and consequently there has been reduced investment in their production. And if you want to ask me why, I'm happy to talk to you about this afterwards. Okay. So in terms of those that are in development and in trials, very few monoclonals are currently in development and in clinical trials. And this worries me enormously because I think this is a great approach. So certainly where I work, we've restarted efforts to discover and develop many, many more antibodies. So we're not in a good situation, and this is a good approach. In terms of what we know clinically, this is a randomized trial of broadly neutralizing antibody to prevent acquisition, right? This is not a cure, this is preventing acquisition, and it was an extremely successful study. It was called the AMP trial, it's published here, and although VRC01, the broadly neutralizing antibody that targets the CD4 binding site, failed to protect in the entire population, study population overall, it provided very strong protection. You see here 75% efficacy when people were exposed to susceptible virus. So that's what's key with these neutralizing antibodies. The virus has to be susceptible for it to work. So in terms of BNAbs for post-treatment control in infected individuals after therapy interruption, I'm showing you two studies here. This study is individuals who were placed on ART at diagnosis with or without broadly neutralizing antibodies, with or without a latency reversing agent, and an ATI was performed after virus suppression. And what you can see here, it's a little bit low resolution, but look at the red lines compared to the blue lines. The red lines is people with resistant virus. The blue lines is people with susceptible virus. And those people who had susceptible virus controlled virus on the BNAb. The latency reversing agent did nothing. This is a study in ART-suppressed individuals who were given BNAb or placebo, who were given this latency reversing agent here before and during the initial phase of an ATI here. This is the placebo. You see the yellow lines, it goes straight up. And with the BNAb, you get a lot who control. So there's a growing number of long-term post-intervention controllers who are being identified in studies with BNAbs given before and during the initial ATI. So we can summarize where we stand with BNAbs. They can prevent infection with susceptible virus. That's pretty amazing. They can delay time to rebound, as expected. They can slow down the rate of virus rebound. Not in all studies, not with all antibodies. Latency reversing agents give no added benefit. BNAbs after rebound can lead to a lower set point viremia. No single study is definitive, but the trends are consistent. The studies are small, but collective data indicate that post-rebound virus dynamics can be modified in some people with some antibodies. This approach alone is clearly not sufficient, which is why we now come in with combinations, or as we like to call it, the kitchen sink approach. Throw everything at the virus. So I'm going to describe here the UCSF AMFAR phase 1 single-arm study, and that was to detect an effect greater than 50%. So you want to see control post-therapy interruption in more than 10%, in more than 50% in this study. You start with a vaccine to elicit GAG-specific T cells. Then you come in with broadly neutralizing antibodies to reduce the size of the reservoir and a TLR9 agonist to enhance T cells. And then you stop ART and you add more broadly neutralizing antibodies and you see if you've blunted the rebound. So what they found was this. 3 individuals had typical rebound. Virus came straight back. This is virus load. This is weeks after therapy interruption. 3 individuals had slow rebound with a slow creep up to around 1,000. 4 individuals, stable control, virus load bobbing along about 1,000 or below. 1 individual controlled completely. So we see sustained control in 7 out of 10 participants. And the mechanism from the work that's going on at the moment at UCSF appears to be related to functional cytotoxic CD8 T cells that have proliferative capacity. So this looks like immune control. Now, in terms of gene therapy, the true cures were a proof of concept basically for gene therapy. The approaches can be to disrupt the HIV proviral genome itself or remove something that HIV needs, such as CCR5. Delivery, however, is a major challenge. We can do ex vivo gene editing of cells outside the body or in vivo gene editing directly within the body. So I'm going to mention nuclease-based gene therapy targeting CCR5 at the moment, and this is how it works. This is a person with HIV, fully suppressed on ART. A leukapheresis is done to take out the T cells which express CD4 and CCR5. An enzyme called a zinc finger nuclease is used to cut the CCR5 gene, rendering those cells CCR5 negative, therefore HIV resistant, and they are infused back in. This approach is minimally invasive, no severe adverse events, much more accessible than stem cell transplantation, and no need for compatible donors or risk of graft versus host disease. So here are two examples. In this study, people with HIV on ART received ex vivo CCR5 edited cells. Here you're comparing it to historical controls in gray, and you can see that there was delayed time to virus rebound after ATI. 2 individuals were heterozygous for the CCR5 deletion, had post-treatment control here in red, and they also had the greatest increase in CD8 T cell responses. And in this study, this is an individual with AIDS who received CCR5 edited cells. He was HLA-B57, that's a protective HLA allele, and he was heterozygous for CCR5 delta 32. 8% of his T cells had CCR5 disrupted in both alleles. He had a delayed time to virus rebound after ATI, unprecedented post-treatment control, and that correlated with potent HIV-specific CD8 T cell responses. Next slide, please. Thank you. There are currently 2 ongoing clinical trials, one of CCR5 gene editing and the other of anti-envelope CAR T cells, which I'm not going to talk about further. Next slide. All right. I told you I wasn't going to talk about animal experiments that looked promising. That was a lie. I'm going to talk about one of them. This is in SIV-infected, ART-suppressed rhesus macaque monkeys. They were given in vivo administration of an adeno-associated virus, which was used to deliver CRISPR-Cas9 gene editing construct targeting the pro-virus itself. And you can see here that after treatment, the CRISPR-treated animals had a drastic reduction in pro-viral DNA in the lymph nodes. There is a clinical trial going on at the moment. This is the company. It's a first-in-human phase 1 clinical trial for safety, tolerability, and efficacy of this delivery of this construct targeting the HIV, GAG, and LTR. It'll be a single ascending IV dose to 9 aviremic HIV-infected adults on stable ART with an ATI therapy interruption at week 12 and follow-up through a year. The estimated primary completion date is December 2024. I am very, very excited about this. I think this is going to be the future of HIV cure. So, to conclude, this is where we were a couple of years ago with daily treatment modalities. Next. This is where we are at the moment with long-acting ART, broadly neutralizing antibodies coming on board. Next. What does it look like in the future? Press the arrow 3 times, please. Well, maybe soon we'll have remission with combination immunotherapy. A bit later, we'll have an ex vivo cure with gene therapy, and then an in vivo cure with gene therapy. And then finally, next. It would be really nice if someone comes into your clinic and says, I've got HIV, and you give them a single shot in the arm and it's a cure. That's what we hope to go for. Next. It will be a long, difficult, and iterative process. Next. The first cure will likely not be able to complete with ART for most people. We really have to be afraid not to call, we mustn't be afraid to call it quits for an approach which is going nowhere. And I think we should have done more of that in the past. Are we going to succeed? Yes, we're going to succeed because that's what we do. We make progress. That's our job. Next. And that's all I've got for you. Thank you very much.
Thanks so much, Danny. That was outstanding. You want to come to the microphone if you have questions? I have a couple real quick. I'm glad to see that we've changed the term from virtual cure to at least remission. That's progress, because it really isn't a virtual cure. And I've talked with Steve Deeks a lot about the notion of the cost immunologically. The host is having to generate a profound immune response, in essence, to keep the virus under control, and that may not be good. So, but I want to ask the one question about the molecular scissors with CRISPR-Cas9. So Chip Schooley, I think, wrote an editorial 20 years ago about, we were taught a long time ago that it's dangerous to run with scissors of any sort, and running with molecular scissors may be difficult as well. How much concern is there in the development of these interventions that we end up doing unknown harm by cutting in places that we didn't intend? How specific can that be, and how sure are we?
So the previous enzymes, certainly the ones 20 years ago, were not very specific, and there are a lot of what we call off-target effects, and it's extremely dangerous. You could cause cancer quite easily. The new CRISPR approaches, and there's a new CRISPR approach every week, which I find annoying because you've got to keep up with it. They really are remarkably specific. And you can use approaches where you combine targeting HIV gag and targeting the LTR. So you find things which are really, really specific, maybe not as efficient or as effective, but you combine them together and you get something that is very effective and very specific. So yes, it's a concern, but as we make progress, it becomes less of a concern.
Okay. Second thing that's a little bit off topic, but I think it fits, that you're talking about development of broadly neutralizing antibodies and different approaches to deliver them. Ultimately, I think a goal would be to create a stimulation of the immune system whereby the host B cells start producing their own broadly neutralizing antibodies. And not only might that help with viral control, but could also be a very effective vaccine.
So there are two approaches for that. The second one, yeah, that's the vaccine. So we're trying to do that for prophylactic vaccines.
Yep.
And it's extremely difficult. These broadly neutralizing antibodies are bizarre. They've undergone many, many rounds of mutation, which is unusual. So our approaches to a prophylactic vaccine are to try and guide the immune system to making these bizarre broadly neutralizing antibodies with multiple rounds of different vaccinations. And we are beginning, as of, I would say, the last 6 months, beginning to see some progress in that field. If it works where the bar is lower with a prophylactic vaccine, then we can apply it in people who are currently infected. There's a gene therapy approach as well, where you can take the genes encoding that broadly neutralizing antibody that you know works, and you can use a gene therapy approach to splice that into B cells in the body so that those B cells start making that pre-made BNAb.
Right, and I think it's important just for historical understanding that broadly neutralizing antibodies were occurring in just a few patients in vivo, where you sort of check their ability to neutralize viruses, and you say, wow, they neutralize a lot. But it took years of that person dealing with their infection, usually without the aid of antiretroviral therapy, for those BNAbs to naturally revolve. So getting a vaccine that'll do that requires markedly truncating that approach. Right. Okay, well, the question is from the audience, what is a profound cure? I think you used that term apparently during the talk.
Did I say that?
Yeah, I think you did.
Those are profound words.
It was profound words and a profound cure, and really it was profound in all directions.
I don't know what I meant by that. I mean, a profound cure could be a true cure, obviously.
Yeah.
It could also apply to a remission, because if, for example, you profoundly silence the HIV genome using a lock and block technique, then you can take someone off therapy and they will be profoundly cured. But I think what I'm going to do, I'm going to add that to my definition.
I like it.
I'm going to have to make something up. But whoever asked me that question, see me after and we'll discuss. And
right,
come
and
up with
sort of quasi-profound.
Yeah.
That you could have variations.
It's like
on
some
that
people
theme.
are kind of quasi-profound.
Yes, indeed. So I don't think people are going to have a chance to talk to you afterwards, so maybe we'll finish with this question that you promised to talk afterwards. But why so many companies have initially purchased the rights to develop a broadly neutralizing antibody and then drop the project. I suspect the answer, like it always is money. It's going to cost. We didn't talk about the cost not only developing a broadly neutralizing antibody to scale it, produce it, get it a good production value is expensive per dose, right?
Are we in a safe space? Am I in a safe space?
Yes, you are.
Okay.
Cone of silence. We're under the cone of silence, so you can.
This is what's been happening. They've licensed exclusive licenses for all these monoclonal antibodies. Initially, it was, well, the cost of making the monoclonals is too high. It's not that high anymore. You can make it. You can bring it down to the same as the cost of a drug. The companies are making drugs, long-acting antiretrovirals. They'd rather sell their drugs, I think, than monoclonal antibodies that they've licensed from the government.
Yeah. And there are, I mean, it always is economics, and it's an interesting dance, right, between developing a new insight scientifically, and then the government doesn't have the ability, nor does it necessarily want the ability to go into the drug manufacturing or business, so they partner with a company, and that becomes a bit of a challenge. Danny, thank you. This was really a fantastic review, and I like the fact that you created a whole new talk for it, because it actually was superb. Thank you.
Thank you very much.
Well done.